All right, so if you're a clinician in training, I guarantee you've seen this. You've got a patient with really distressing GI symptoms, but every single test you run comes back completely normal. So what do? Well, today we're going to demystify these conditions, now known as disorders of gut-brain interaction. We're going to tackle the huge disconnect between the super strict criteria used for research and what you actually need to do to help patients in the real world, in your clinic.
So here's the game plan. We'll start with that classic dilemma, the diagnosis of exclusion. Then we'll talk about how the Rome criteria came along and cleaned things up for research. After that, we'll get into the clash between research rules and clinical reality. The good news is there's a new clinical compass for us to use, and we'll wrap up by talking about how to put all this into practice. Let's get started.
All right, first up, the diagnosis of exclusion. This is really the clinical dilemma that kicked this whole thing off. So, picture this. You're sitting with a patient, and they are in real distress. They're telling you about bloating, pain, bowel habits that are just wrecking their quality of life. So you do the right thing. You run all the tests, endoscopy, imaging, blood work, the whole shebang. And nothing. Everything's normal. For decades, this was a dead end. Clinicians were totally stuck. And worse, patients often walked away feeling like we didn't believe them, leaving us with no clear path forward.
And for the longest time, we called these functional gastrointestinal disorders, or FGIDs. Now, the idea was that functional meant it was a problem with how the gut worked, not its actual structure. But let's be honest, that term was not great. It was vague, and for patients, it often felt like we were saying their symptoms weren't real, that it was all in their head. It created a real stigma.
And that's exactly why the field moved to a much better, much more accurate term, disorders of gut-brain interaction, or DGBI. And listen, this is way more than just a name change. It's a total shift in how we think about these conditions. It puts that complex, superhighway of communication between the gut and the brain right where it belongs, at the absolute center of what's going wrong. So, when you look at the official definition, you see it's pretty broad, and for good reason. DGBI isn't just one thing. It covers a whole host of potential issues. We're talking about everything from how the gut moves, to how sensitive it is, even the immune system, our gut bacteria, and, this is key, how our brain is processing all those signals from the gut. The big takeaway here, it's a network problem, not just a plumbing problem. Okay, so how on earth did we go from that vague diagnosis of exclusion to this much more sophisticated network-based way of thinking? Well, it all comes down to creating a standard for research. To really get why this was so important, check out this quote from a 1988 review of clinical trials. It's pretty blunt. It basically says that not a single study on IBS was using a good definition of the condition. Think about that. It was the Wild West. How can you possibly run a reliable trial if everyone is studying a different type of patient? You just can't. It was complete chaos. So out of that chaos came the Rome process. Starting back in the late 80s, experts from all over the world got together to create some actual rules. And over the next 30 years, this effort evolved through Rome I, II, III, and now Rome IV, eventually becoming the absolute gold standard for any research in this field. And this right here is the absolute key point. The whole goal of the Rome criteria wasn't really for your everyday clinic visit. It was to legitimize the science. By creating these super specific definitions, researchers could finally study consistent groups of patients. Comparing apples to apples. And that is absolutely non-negotiable if you want to do good science and get new treatments approved by agencies like the FDA. But, and this is a big but, this brings us to the central problem. What happens when that rigid ruler, so perfect for research, meets the messy, complicated reality of an actual clinic? Well, that's where things get tricky. And here's exactly where that friction shows up. The Rome IV research criteria say symptoms have to be around for at least 6 months. But think about it. Who's going to wait half a year to see a doctor when they're feeling awful? Nobody. Then there's frequency. The criteria use these really high statistical cutoffs, but you know as well as I do that a patient can have symptoms less often and still have their life completely turned upside down by them. And the real-world impact of these strict rules? It's huge. Just look at this number. When the criteria for IBS got even tighter, moving from Rome III to Rome IV, the number of people in the world who qualified for the diagnosis dropped by half, 50%. Now, did half the people with IBS magically get better?
Of course not. It just meant that millions of suffering patients no longer fit into this neat little research box. So what's the result of all this? Well, it puts clinicians like you in a really tough spot. You know your patient has a gut-brain disorder. You can see it clear as day. But they just don't tick every single one of those rigid research boxes. And that leads to this diagnostic limbo, where you might delay giving them a real diagnosis. Or you order even more expensive, unnecessary tests just to be sure you're not missing something.
Okay, so here's the good news. Recognizing this major disconnect, the people behind the Rome criteria have proposed a better way forward for clinicians, a set of guidelines designed specifically for your practice. Think of it as your new clinical compass. And the absolute cornerstone of this whole new approach is one simple but powerful word: bothersomeness. This is the game changer. It shifts the focus away from counting symptoms per week. Instead, the question becomes, are these symptoms messing with the patient's life? Are they causing them to worry, to change their plans, to feel impaired? Because at the end of the day, that's why they came to see you in the first place. So this gives us 4 really practical factors to use in the clinic. First, does the story fit? Do the symptoms sound like a classic DGBI pattern? Second, the big one, are they bothersome? If you've got a yes to both of those, then you have way more flexibility. The frequency doesn't have to be so high. And the duration? We're talking maybe 8 weeks, not 6 months, as long as you've reasonably ruled out any red flags. This whole approach is also backed up by another huge mental shift from Rome 4. We have to stop thinking about these disorders as separate, tidy little boxes. It's really more of a spectrum, a continuum. For example, a patient with IBS with constipation isn't some totally different species from a patient with functional constipation. The main difference is the addition of significant pain. Thinking this way helps us be a lot more flexible and accurate in how we see our patients. Okay, so let's land the plane. How do you actually put this into practice? And more importantly, why does this matter so much for both you and your patients?
Here's your new thought process, and it's pretty straightforward. Step 1, do the symptoms match a known pattern? Step 2, are they bothering the patient? Step 3, have you done your due diligence and ruled out the scary stuff? If you get yes, yes, and yes, then you move to step 4. You make a confident, positive diagnosis. You're no longer saying, we can't find anything wrong. You're saying, I know what this is. It's a disorder of gut-brain interaction. And the benefits of doing this? They're massive. First off, when you give a patient a real positive diagnosis, they feel heard and are so much more likely to accept it. That right there strengthens your relationship. It also means you can stop the endless cycle of unnecessary expensive tests. And the best part, you get to start effective treatment way, way sooner. It's a win for everyone. So, to wrap this all up, this new clinical framework is a huge leap forward. It finally closes that gap between the research lab and the exam room. And the most important thing is that it empowers you, the clinician, to give your patients better, more confident care. But it also leaves us with a really exciting question for the future, right? Now that we have a solid clinical standard, what's the next frontier? Is it going to be personalized biomarkers to see exactly what's happening in the gut? Or is it better psychosocial tools to really tackle the brain part of the gut-brain axis? I guess that's the next chapter we all get to watch unfold. Thanks for tuning in.